Hello and welcome. Today we are going to tackle a critical topic you will frequently encounter on the wards: acute decompensated heart failure. We will walk through a step-by-step clinical management guide, taking you from the moment the patient arrives in the emergency department all the way to a safe discharge plan. This is designed for medical students and residents review. Before we begin, it is crucial to understand that this presentation is for educational purposes only. It is not medical advice and must not be used for direct patient care or clinical decision-making. Always consult the full, most current clinical guidelines and perform your own independent analysis before making any clinical decisions. When a patient with acute decompensated heart failure presents, it can feel overwhelming. To bring order to the chaos, we use a structured, 5-step roadmap. First, how sick is the patient? This is your initial triage and stabilization. Second, what caused the decompensation? We must always hunt for the trigger. Third, medical therapy. This is where we deploy our core treatments like diuretics. Fourth, the transition to discharge, a critical phase where we switch from intravenous to oral medications. And finally, step 5, advanced planning, which includes setting up close follow-up and optimizing long-term medications. Let's break these down one by one. Step 1 begins at the bedside. The most important initial question is, how sick is this patient? We can classify them rapidly using the Nohria 2x2 grid. This elegant tool requires you to assess just two things: congestion and perfusion. Is the patient wet or dry? And are they warm or cold? A wet patient has signs of volume overload, like edema or elevated jugular venous pressure. A cold patient has signs of poor perfusion, like cool extremities or a narrow pulse pressure. The most common profile, representing over 70% of patients, is warm and wet. These patients are congested but still perfusing adequately. The most ominous profile is cold and wet, as these patients are both congested and in a low output state, which carries the worst prognosis. While most patients are warm and wet, you must be able to identify those who need immediate escalation to the intensive care unit. Here are 8 critical escalation triggers that demand ICU-level care. Hypoxia, with an oxygen saturation of 90% or less despite supplemental oxygen. Significant respiratory distress, with a respiratory rate over 25 or use of accessory muscles. The need for advanced respiratory support like non-invasive ventilation or intubation. Hypotension, with a systolic blood pressure under 90, or any signs of hypoperfusion. Significant bradycardia or tachycardia. Overt cardiogenic shock with cool, mottled skin and altered mental status. Symptoms that are refractory to your initial treatments. And finally, worsening renal function that may require advanced therapies like ultrafiltration or dialysis. If you see any of these, your patient is unstable and needs a higher level of care immediately. Next, let's talk about biomarkers and a common clinical trap. B-type natriuretic peptide, or BNP, and its precursor, NT-proBNP, are powerful tools to help differentiate cardiac from non-cardiac causes of dyspnea. A BNP less than 100 or an NT-proBNP less than 300 makes heart failure very unlikely. However, you must be aware of the Entresto effect. Sacubitril valsartan inhibits neprilysin, which is the enzyme that breaks down BNP. This leads to falsely elevated BNP levels, but it does not affect NT-proBNP. Therefore, you should use NT-proBNP to monitor patients who are on Entresto. Also, be aware of other pitfalls. False lows can be seen in obesity, and false highs can be seen in renal failure, old age, and atrial fibrillation. The key takeaway is to use these markers for initial diagnosis and prognosis, not to guide therapy, as the Guide-IT trial showed no benefit to serial BNP-guided treatment. Beyond the labs, several diagnostic tools are essential. The ECG is the initial screen. You should look for signs of ischemia, arrhythmias like atrial fibrillation, left ventricular hypertrophy, or low voltage, which might suggest amyloidosis. Next, the chest X-ray. Look for an enlarged heart, pulmonary venous congestion, and pleural effusions. But be aware of a common trap. Patients with chronic heart failure may have a surprisingly clear chest X-ray despite being very congested. The gold standard imaging test is the echocardiogram. It assesses the left ventricular ejection fraction, diastolic function, valvular disease, and wall motion abnormalities. For select cases, advanced imaging like a cardiac MRI can identify infiltrative diseases, and a cardiac catheterization may be needed to define coronary anatomy or, in refractory cases, to directly measure heart pressures with a right heart cath. Beyond your basic labs, several key markers help you risk stratify your patient early. Don't just order them. Understand what they mean. An elevated troponin indicates myocyte injury and is associated with higher mortality, but remember to always rule out an acute coronary syndrome. Worsening renal function, reflected by a rising BUN and creatinine, is one of the strongest predictors of poor outcomes. Hyponatremia, or a serum sodium less than 135, is not just an electrolyte abnormality. It reflects severe neurohormonal activation and correlates with disease severity. And finally, elevated liver function tests, or a shock liver, suggest severe congestion or a very low cardiac output. These labs give you a crucial early window into your patient's prognosis. For the patient in significant respiratory distress, non-invasive ventilation, or NIV, is a critical tool. This includes CPAP or BiPAP. The indications are clear: severe respiratory distress, acidosis, or hypoxemia despite high-flow oxygen. The benefits are immediate. Non-invasive ventilation reduces the work of breathing, and by increasing intrathoracic pressure, it effectively reduces both preload and afterload, which is a huge benefit in acute decompensated heart failure. It can rapidly improve oxygenation and often prevents the need for intubation. However, be cautious. NIV is contraindicated in patients with altered mental status who cannot protect their airway, those with hemodynamic instability or shock, or those who are actively vomiting. Once the patient is stabilized, we move to step 2, finding the cause. There is always a reason for the decompensation. A useful tool for this is the failure mnemonic. F, for forgot medication or taking harmful drugs like nonsteroidal anti-inflammatory drugs. A, for arrhythmia, like new-onset atrial fibrillation or anemia. I, for ischemia, infarction, or infection. L, for lifestyle choices, like a high-salt meal or alcohol use. U, for upregulation of metabolism, as seen in thyroid disease or pregnancy. R, for renal failure. And E, for embolism, specifically a pulmonary embolism. Identifying the precipitant is not an academic exercise. It directly changes your management. Now we arrive at step 3, medical therapy, the cornerstone of which is intravenous loop diuretics. The timing here is critical. Guidelines recommend giving the first dose of intravenous diuretics within 60 minutes of arrival. The only major exception is the patient with severe hypotension or cardiogenic shock, where you must stabilize their hemodynamics first. Dosing is equally important. For a diuretic-naive patient, a standard starting dose like 20 to 40 milligrams of furosemide is reasonable. But for a patient on chronic home diuretics, you need to be more aggressive. The initial intravenous dose should be 2 to 2.5 times their total daily oral dose. Early and adequate dosing is key to preventing worsening congestion and subsequent renal injury. How do you know if your diuretic dose is working? You must follow the 2-hour rule. 2 hours after your initial dose, you need to assess the response. A poor response is defined as a urine output less than 100 to 150 milliliters per hour, or a spot urine sodium less than 50. If you see this, do not wait for the next scheduled dose. You must escalate therapy immediately by doubling the diuretic dose. Repeat this until you achieve a response. If the patient remains refractory, your next step is sequential nephron blockade. This means adding a thiazide diuretic, like metolazone. This is a powerful combination, but be aware of the risks highlighted in the chlorotic trial: hypokalemia, hyponatremia, and worsening renal function. For the most refractory cases, you can consider a continuous diuretic infusion, though the dose trial showed no major difference in outcomes compared to bolus dosing. And as a last resort, ultrafiltration can be considered. As you diurese, it's critical to know your targets. Your goal is freedom from clinical congestion. This means resolution of orthopnea, a jugular venous pressure less than 8, and the absence of significant edema or RALs. These are good targets. What are bad targets? Relying on symptoms alone is a common trap. Patients can adapt to chronic congestion and may feel at their baseline, while still being significantly volume overloaded. Chasing a dry weight is also unreliable. And finally, do not panic at the first sign of a rising creatinine. A mild increase may be a permissive hemodynamic effect of successful decongestion. However, before you accept this, you must rule out other causes of renal injury, such as obstruction or exposure to other nephrotoxins. For sicker patients, we may need advanced therapies. Let's simplify their use. Vasodilators, like nitroglycerin, are for patients with severe hypertension or acute pulmonary edema. Avoid them in patients with symptomatic hypotension. Inotropes, like dobutamine or milrinone, are reserved for patients in cardiogenic shock, the cold and wet profile. It is critical to remember that routine use of inotropes is harmful and increases mortality. And a key clinical trap to avoid: inotropes are rarely beneficial in patients with heart failure with preserved ejection fraction. Finally, vasopressors, like norepinephrine, are for patients in persistent shock despite inotropes, with the goal of maintaining perfusion to vital organs. A common question is what to do with a patient's home medications. The modern approach is clear: initiate or maintain guideline-directed medical therapy, or GDMT, during the hospitalization. This is built on 4 pillars. First, renin-angiotensin-aldosterone system inhibitors, which include ACE inhibitors, ARBS, or an angiotensin receptor neprilysin inhibitor like Entresto. Second, evidence-based beta blockers. Third, mineralocorticoid receptor antagonists. And fourth, the new standard of care, SGLT2 inhibitors, based on trials like Impulse. The golden rule is to start or continue all 4 pillars in the hospital once the patient is stable. A critical safety rule: if you are switching a patient from an ACE inhibitor to Entresto, you must have a 36-hour washout period to prevent a dangerous angioedema reaction. The future of heart failure therapy is exciting. Keep an eye on these new and emerging therapies. Sotagliflozin is a dual SGLT1 and 2 inhibitor. Vericiguat, studied in the Victoria trial, is a soluble guanylate cyclase stimulator. Myosin activators, like omecamtiv, aim to directly enhance cardiac contractility. And on the horizon, gene therapies are being developed to target the underlying genetic defects that can cause heart failure. Now we move to step 4, the transition to discharge. This is a high-risk period. Before a patient can go home, they must be stable on an oral diuretic regimen for at least 24 hours. You cannot send a patient home the same day you stop their intravenous drip. Every patient must also have a clear, simple rescue plan. For example, if your weight goes up by 3 pounds in one day, take an extra diuretic pill and call the clinic. Finally, always check their potassium levels after the switch to ensure they are stable on their oral regimen. Step 5 is about preventing readmission. The first 30 days after discharge are the most vulnerable. A follow-up phone call should occur within 2 to 3 days. A clinic visit must be scheduled within 7 to 14 days. And the discharge summary is a critical communication tool. It must clearly state the patient's discharge weight, their final medication list, and the details of their follow-up plan. Let's summarize the key traps to avoid and the triggers for escalation. The common traps are delaying intravenous diuretics, chasing BNP numbers instead of relying on your clinical exam, reflexively stopping beta blockers, using inotropes in heart failure with preserved ejection fraction, and failing to search for the precipitating cause. The key escalation triggers that mean your patient needs the ICU are respiratory distress, hypotension or shock, and worsening renal function that requires dialysis. So, let's bring it all together in a final recap. This is your acute decompensated heart failure checklist. 1. Triage the patient using the warm/cold, wet/dry classification. 2. Find the cause using the failure mnemonic. 3. Treat early and aggressively with intravenous diuretics, using 2.5 times the home dose for chronic users. 4. Monitor the patient using your clinical exam, which is more important than any single lab value. And 5. Plan for a safe discharge with a 24-hour oral diuretic trial and a scheduled, close follow-up. And the final, most important message: this video is a guide. Always read the full guidelines and perform your own analysis for every patient you treat.